Good afternoon and welcome to today's episode of Surgery Online. We have an exciting topic here today for you, which is about bone conduction. And the name of the event today is Bonebridge BCI 602 implantation and simultaneous removal of percutaneous bone anchor. So this is a topic which gets more and more important nowadays as more and more patients would like to upgrade from a classical bone anchored bone conduction device to a more modern active transcutaneous device like the Bonebridge. First of all, if you already know Surgery Online, you know that we always talk about those housekeeping rules. If you're new, then I would just like to remind you that you should name yourself so that we know to whom we are talking here today. You can do that by just clicking on your name and go to more and then to rename yourself. We would like to ask you to try to avoid any background noise. You will be muted and you cannot unmute yourself, but afterwards when we will have a discussion, we will give you the option to talk to us, and when we do so, please try to do not have any background noise like smartphones or whatever. And for a stable internet connection, we recommend to close all other programs in the background, like MS Teams, for example, so that the whole bandwidth can be used for this Zoom meeting here today. And I would like to point out that all of your comments and questions are highly welcome. So if you have any question during the talk, then please just type it into the chat or save it for later, and then actively participate to this event here today. Before I would like to introduce you to our speaker of today, I just prepared a few slides in order to introduce you to the topic of today. As we are talking about removing classical bone-anchored bone conduction devices, we have to talk about the reason why we want to do that, and this is usually complications which occur with those devices. And we as a company, we always wanted to have a different approach, not to use those bone-anchored percutaneous devices. And this is why we developed more than 10 years ago the Bonebridge system, which back then was the first transcutaneous active bone conduction device on the market. And in those last 10 years of experience, we discovered that there is 4 important bullet points which contribute to the low complication rate with the Bonebridge. And those points are first the implant reliability, the impact safety, the skin safety, and also the MRI safety with the device. And on the next slides, I would like to go a bit more into detail about that. Let's start with implant reliability, so the technical reliability of the device. And here we already have 9 years of data available for the first generation of the Bonebridge system, which is the BCI 601. And we are very happy that even after 9 years, we have very high cumulative survival rates, which are almost 98% for the Bonebridge. And what we are also really happy is that for children, this number is even higher. It's more than 98%. So you could expect that an active child, which might fall down on the implant site, could be prone to more defects in the implant, but this is definitely not the case, as we can see here from the numbers. Now for the newest generation, the BCI 602, which is on the market for more than 2 years already, we also have numbers, and here the numbers look even better. So we have more than 99% of cumulative survival rate for this device. And also here, especially for children, the numbers look very, very good, because here we have 100% reliability at the moment. The second thing which contributes to very low complication rates is impact safety. And here it is actually 2 features. It's the recessed design, which we are using, and also the 2-point fixation. Recessed design, what does this mean? We believe that it is much safer to have the BCFMD, so the transducer of the device, safely embedded into bone, because this makes the leverage forces which apply to the transducer, if there is an impact from the outside, very low or even 0. And the other thing which is very important here is the robust fixation. And here we believe in a 2-point fixation. So we are using 2 screws in order to fix our implant. And also here, this has leverage reasons. So there is no leverage force on the screws. If you would imagine, for example, that the transducer only sits on 1 screw, then of course, if you get impact from the outside, this could cause leverage and forces on the screw, and the screw could the connection could get loose. And the other thing which is very important is that the Bonebridge fixation does not rely on osseointegration. So as soon as the wound is healed, the audio processor can be used, so there is no waiting time for osseointegration. But over time, the screws will osseointegrate, of course. The other thing which is really important, of course, is skin safety. And here, the active transcutaneous technology, of course, contributes to very low complication rates, and also the very gentle design which we are using towards the skin. About active transcutaneous technology, there had been a white paper published which goes very much into detail about that, and we can just see one graph out of this white paper, which emphasizes on the low complication rates of transcutaneous active devices like the Bonebridge. You can see it on top, and we can see in those different shades of green the complications, minor complications, major complications, and sequelae of those complications. And we can see that the Bonebridge is much better than percutaneous devices like the Ponto or the Baha Connect, for example. And astonishingly, the transcutaneous passive devices like the Attract or the Sophono are even worse. They require a lot of skin pressure in order to deliver the vibrations to the bone, and this is the reason why a lot of skin irritations happens in those patients. And of course, for the percutaneous devices, there's a lot of wound problems around the abutment which cause complications. And the other thing is the design of the whole implant, which is very gentle to the skin. We believe here in a recessed design, meaning that the transducer rests embedded in bone, and there is only a little protrusion above the bone, meaning that the skin stress is very low. Compared to other transcutaneous active implants on the market, which use a top-mounted design, which means that the transducer sits on top of the bone. Of course, there's a lot of volume between bone and skin then, and this means that there is a high stress towards the skin, which is feelable, of course, for the patient, but it's also perceivable from the outside. So usually you can see that there is something below the skin, especially in children where the skin is, of course, thinner than in adults. Last but not least, I would quickly like to talk about MRI safety, which is not only important for bone conduction devices, but all implants from MED-EL. We have MRI safety, and we also have an MRI guarantee here. MRI safety for the Bonebridge is MRI conditional at 1.5 Tesla, meaning that we are using a very special technology which allows hassle-free MRI scans without the need of a magnet removal. And with that, there is no surgery needed before and after an MRI, and with that, there is no hearing downtime for the patient. And this is also true for our other implants. We are very sure about our MRI conditionality, and this is why we have this MRI guarantee. We have a lifelong guarantee. So if something would happen during an MRI, we provide new implants because we are so sure that there won't happen anything if you do the MRI scan according to our conditions. Okay, and with that, this is enough for an introduction. Let's now come to our guest speaker for today, who is Professor Robert Mlynski. He is the clinic director of the ENT department of the University Clinic in Rostock in northern Germany. And he is going to share a nice Bonebridge case with us today. Professor Mlynski, can you hear me? Are you with us?
Yes, I can hear you very well. Thank you, Patrick.
So whenever you're ready, please take it over from here.
Yes, thank you very much for the kind introduction. I'm starting my presentation, which you should see now. Is that correct?
Yes, yes, works very well.
Excellent. Yes, good afternoon, everybody. I'm broadcasting here from Rostock in Germany. That's up in the north of Germany. It's it's at the Baltic Sea up here. Sun is always shining, of course, whenever it is raining somewhere else. And Rostock has the third oldest university in Germany. Only Heidelberg and Leipzig are older places, and it was founded in 1419. And also we have the oldest university ENT department, which was founded in 1894 by Otto Körner. That was it was looking like in 1899, and that's what it is looking like today. And Otto Körner, I think everybody is familiar with. He was an otologist who was scientifically describing the connection between temporal bone infections and intracranial complications of the brain, the dura, and the vessels of the brain. And that's why the Körner's plate was named after him, the ossified suture of the petrosquamous bone. However, we are going to talk about a case of a patient with bilateral malformation. The boy is now 18 years old. He has had a long history of surgeries at the outer ear and the temporal bone. He was treated with percutaneous bone anchored devices in the early 2010-11, and he had recurrent infections around his abutment and needed a surgical debridement of the skin, and that's why he was treated in 2017 when he presented to us again with the Bonebridge, with the BCI 601 on the left side, with a retrosignal placement of the bone conduction FMT. And today we are showing you the surgery of the implantation of the BCI 602, which took place in August 2019 with simultaneous removal of the percutaneous bone anchor. These were wobble thresholds of the patient in 2008 when he was in our department for a screening. He is from far away. North Germany is like Australia. There's lots of outbacks, and people have to travel a lot and long time, and sometimes never come back. However, this patient was treated somewhere else with the Bahas and then returned in 2017, and we treated him again also with a simultaneous removal of the bone anchor and the BCI. And you see now here the wobble thresholds. The boxes are with the Bonebridge, and the rhombus is with the former Baha. Then he took him a while to come back, and we decided for the bilateral treatment. This was the Puton thresholds right before the second site, and this is now the CT scan, and you can see the malformation of the temporal bone, high jugular bulb, almost no aeration on the right side, and here the bone, the abutment still in place, and you can also see it is penetrating to the bone. So actually on the right side, the skin was overgrown on the implant, and this is the auricle with the outer ear canal, which is very narrow, and we are doing an S-shaped incision retroauricular, which is not shown in the video right now. But I just wanted to present you what the patient is looking like here. We are not using this scar, which was used, or this approach, this skin incision, which was used for the Baha placement. And there we now expose the abutment of the implant, which was fully overgrown by connective tissue and skin. So sharp incision on the skull, and then using a respiratory to displace the pericranial connective tissue. And it is necessary to fully expose around the former implant, expose the former implant completely. So we have to really make sure to have a circular view around the implant. And what else you can observe, or what can be seen, is that this implant in this case is very well osseointegrated. So there's no doubt that you can remove it by unscrewing it or whatsoever. You have to remove the implant by drilling out the bone around the implant. I will show you a picture later. And this is important. So there's no hope to remove this implant if it is properly osseointegrated by the screwdriver or a wrench. So now it is fully exposed, and we will drill out the implant. I will show you some pictures of the osseointegration of formerly removed implants from other patients, not of this one. So what actually happens is in osseointegration that the bone is actively growing on the titanium oxide, and the matrix of the bone goes onto the bone. So there, you cannot unscrew this implant. So you have to. And now I would like, Patrick, you to share the video, the proper video of our surgery. So, ich habe die Steuerung noch nicht, doch, jetzt habe ich sie. Genau. Danke. So the first step, skin incision, retroauricular, S-shaped like incision. We have removed, or we have placed the we have placed the skin and the opposing pericranial flap. We have exposed the implant, and now using sharp and diamond drills in order to remove the bone around the previous implant. So in the CT scan, we already could see that the implant is penetrating the skull. So we can see the dura, and now slowly remove the implant together with the surrounding bone from the skull. And we can see that here is the transverse sinus exposed by the implant, or was in touch to the implant. This can cause sometimes head and neck pain or head pain. So it might be also a good reason to remove penetrating implants. Then next step is the creation of the bone bed for the BCI-FMT. And as you remember, the patient had a hypoplastic temporal bone. So even measurements will show that we are getting very close to the dura. And we will see now technique in order to do a bone bed, even with exposed dura, and how to preparate the bone if the dura is very narrow to our implant bed. So we line out the outer diameter of the BCI-FMT, and as closer we approach dura or sinus, which can be seen in the inferior right part of the bone bed, with the white color and this vessel kind formation around. We leave a small peninsula or small insula on the dura, which now can be pressed inwards, slow, very gentle. And the dura is separated from the skull. These very little indentation or impression of the dura is no problem whatsoever. Of course, it's only 1 or 2 millimeters here. And now we lift or impress the dura from the skull, and we now can, with the diamond, drill the tabula interna of the bone. And later, the dura can flip back to the skull, and we can place our implant. We are using a diamond burr when preparating close to the dura. Continuous irrigation, high-speed drill, 40,000 rotations per minute, and intermediate or in between, we always use the sizer and the dummy for the implant. And now you see the dummy for the coil and the BCFMT together with the millimeter or the measurement device, in order to get to know how deep your bone conduction FMT will be in your bed. Fixation of the BCFMT is with the onboard screws with the implant and the onboard screwdriver you can see here. And these are self-drilling and self-tapping screws. And here is the intersect or transition to the coil, which can be bent in order to have a convenient placement of the implant. What is convenient? It is if the implant stays parallel to the skull and has no bulking and is not rocking at all. Especially rocking of the coil is not advisable, because if it rocks, you have movements. Movements cause bleeding, cause what is it? Cause fluid around the implant, and fluid around the implant can always cause infection. So with the screwdriver, we fix the implant. Always remember not to overturn not to overturn the screws. So it should be handfast. Actually, one screw, both screws should be in place, and one screw after another is tightly screwed in the end. So that's basically it. Implant is now fixed. We close the flaps over the implant. So the incision lines are placed that we don't have a direct cut from the skin to the implant housing, meaning the pericranial flap and the skin flap are opposing each other, so that no incision line is parallel to each other. So they are crossing, so we have only minimum overlapping of the incisions. The closure is with 3-nil vitriol. That's a resorbable suture. And here you can see again the S-shaped retroauricular incision, which is in far distance to the previous incision line, and in far distance to the coil. So the suture is being, the final suture is with non-resorbable monofile Resolone 4-nil. Okay, that's it. So we get back to the presentation. Here we are. So here are the post-operative speech audiometry of the patient. I have to. As a German-speaking patient, so we use monosyllabic and polysyllabic words. So he has 100% speech perception at 65 dB in polysyllabic words, and 70% on the right side with monosyllables. This surgical technique you can also read. I can recommend this paper, which is published in the German ENT journal, which is but it's published in English, so you can also read it in English. And I'm now finished with my presentation. Thank you very much for your attention. You're also kindly welcome to Rostock for our annual surgical course for hearing implants and microsurgery of the year. And I'm open to questions now.
Thank you very much, Professor Mlynski, for this detailed walkthrough through your surgery. I can see that we already have one question in the chat window from Timo Brecker. Timo, would you like to unmute yourself and ask your question, or should we just read it out? Okay, I'm not hearing anything, so I will just... Okay.
I can read it loud because it was very interesting. Thank you very much. It's a question related to the removal of the Baha implant. I didn't get it right, perhaps, but what could have happened while trying to turn out the Baha implant screw directly? Was it too difficult to turn it, or?
The force being necessary to unscrew it is so immense high that it just won't work. You will destroy the screwdriver, or you will destroy the wrench, you will destroy the abutment, but you will never be able to move the implant in the turns of the bone.
Interesting. Thank you.
Mm-hmm. Maybe related to that, we saw it already in the CT scan that the Baha screw was in contact with sigmoid sinus, and you mentioned that this could cause headache. Imagine that it would not be in contact. Would you still then take the abutment out, or could it be an option to leave it in as well?
Yeah, well, the reason here was definitely not the headache or pain. And the reason here, of course, is we have a foreign body in the skull, which is close to our future implant. So we don't need it. It's no risk, it's no harm to remove it. So always, I think it's better to remove it.
Mm. All right. Then we have a question from Jeffrey Ball. Jeff, would you like to unmute yourself?
So hi, Jeff. It would be a pleasure to see you actually and hear you.
Can you hear me?
Yes, I can.
Oh, sorry. Yeah, hey, so Mike, how are you today?
Thank you very much.
Hey, I can see your office with all those terrible devices in the background that you have. You know, everyone doesn't know, but he has a museum of horrifying devices. You just have to see it sometime. It's good to see you, and missing Rostock, best place ever to get your implant done. And you know, I was wondering, when OSIA started originally, one of the ideas was that they were going to take existing patients and then like somehow put the transducer onto that part, the implant part. And I don't think it's ever been done. And after looking at it, I don't think that they really achieved that design goal. Has it been done? Do you think it can be done? What do you think? I mean, I think it's kind of a good idea.
Yeah, well, I must say I don't have any experience with the OSIA. My concerns about putting the OSIA directly on the fixture which is in place is that you must make sure, or the idea of the OSIA is to have a very planar position to the skull, otherwise you have bulking. So whenever, I think an abutment with the percutaneous Baha on top is maybe a little, it might one or two degrees off the optimal axis might not be as bad as if you have this right plane. But actually, I don't have an idea. And another thing is that they had at a certain time, they were advertising at least so-called fast-track surgery. So there was the abutment and the fixture in a single piece, and even I think a one-piece device. So not the abutment being removable from the flange fixture. And in those cases, I would think it can't be possible to do so. So, yeah.
Well,
actually,
it just sort of, after watching what you did, it just seems like it's sort of counterintuitive, but it's actually a good thing to be able to put something in and get it osseointegrated. It's also kind of important in the future to be able to get it out. And it's not so easy.
Exactly. Well, this can be, is really, we have many, we actually, bars, we are more explanting than we never implant them. We want this osseointegration in patients where we have mid-facial or other plastic reconstructions after cancer surgery or trauma. There we want to have these fixtures obviously very well osseointegrated in order to put epithesis on the skull. But here it's obviously, of course, a pain in the neck to get them out, and it looks a little brutal.
Well, the other thing that occurred to me just watching the thing is that it's sort of an overkill design, because you have full osseointegration, which is important for a dental implant where you have tremendous forces on the mandible, but you don't really need that, you know. So it's they're sort of still married to that single mono unit design, which, you know, you'd think, well, you have two screws, one, we only have one, but two is actually kind of makes sense there. If you can get down.
Of course, the Baha had its time then when there was no alternative. I mean, it took a while until some American nice guy, fine chap, came away and along and invented some really good implants. But now I think the Bonebridge and the Soundbridge are the main working horses for treatment of these patients.
No, and to be fair, I will say Osai is better than a percutaneous plug for the patients.
Definitely. So there was one question from Alex Bennett to everybody. If the infected abutment was penetrating through the skin, would you still have done this as a single procedure? Actually, this is an excellent question. No. Then we would do staged surgery. And also in this case, if you would have seen debris or any signs of infection around the closed skin, around the implant of this beneath the closed skin, we would have done a two-stage surgery. So in our regular patients where we remove Baha and put in a BCI or a Soundbridge, we will do one-stage surgery for the removal of the abutment, which can be done in sometimes local anesthesia, close it and close the skin. We leave, if the abutment can be removed, because then we close the skin and do the fixture removal together with the placement of the new implant. You get it? Mm-hmm. So this spares the patient from two narcosis, and the removal of the abutment, leave the fixture in, is under local anesthesia, one stage, second stage in anesthesia.
Mm-hmm. For the placement of the coil section of the Bonebridge in such cases, do you try to avoid having the same position as the abutment was before in order not to have the audio processor on scar tissue? Exactly. Or do you use this? Okay.
Yeah, I think it's best to have the coil under intact skin and untouched skin, because the skin, the scar tissue always has less vascularization. And if you put continuous pressure from the force of the magnet on top, it could be a problem, and we don't want to have any necrosis or things like this. I have never observed it, but surgical strategy is to place the coil away from any scars.
Okay.
So
we have another question from Asenda Makunga. The idea of displacing the dura to make space for the implant, do you have experience with it on other patients?
yes, I think about 10% or 50% of our patients have contact, has the BCI has contact to the dura. It is no problem usually, and we don't do CT scans for epidural hematoma. I think this is without clinic not necessary. I mean, we are doing worse displacements in temporal bone surgery without doing post-operative CT scans.
Then we have another question from Robert Wieck. Do you leave a bone bed when compressing the dura? Okay, and he specified it more, he made it more clearly, I mean a blade.
Yeah, what we do, I hope we could see it, otherwise I can show the presentation again if you don't mind. So what we do is we leave a peningula or an insula on the dura, and we use the suction to compress sinus or dura, and then we can take the drill to flatten the bed, and then when you lift up the suction again, everything gets back in place, and so that is the idea of it. Does that answer your question, Robert Wieck?
I think so. And this bony island it's not just for drilling use, but it also stays then in order to be a safe layer towards the dura.
It's back, it has then touches the BCFMI, BCFMT.
All right.
Does anybody, have you seen the audiogram? I was expecting some questions to the indication of the Bonebridge in this patient. No questions on this?
The bone conduction thresholds looked quite low.
Yeah. Robert Wieck has another question again. I don't know. I've never removed the Bonebridge, so I cannot tell you what happens with the bone beneath it. But it could be possible that it is growing back. But actually, I would not expect it, honestly. What we see is in revision surgeries, when you do a cochlear implant in a baby and a couple of years later, when it's addled and needs to be changed, then the corticalis lateral is grown back. But in the older implants, like the big cochlear implants with or the Combi 40, where sometimes in babies also the dura was exposed, when you remove those housings, usually it's still, the dura is still there. So I expect that intracranially we don't observe the closure of damaged internal tabula. Yeah.
Jeff, you have another question?
Yeah, just out of curiosity, can you hear me?
Yeah.
Okay, yeah, I was wondering, what do you think about sometimes like I used to get asked for the sound bridge and not too much for the bone bridge, but they have this thing called a butterfly burr, and you could make a perfect butterfly burr that goes on and then it would make a single. What do you think about that? It doesn't seem to be such a great concept. Have you ever used one of those?
So Jeff, I have no clue what a butterfly drill is.
It's like a really wide, instead of a single burr, it would be the OD would be the size of the bone bridge, and so then you just go, and then you have a little stopper.
Oh, that's maybe the drill from the neurosurgeons for trepanation.
Yeah, they have something like that. I mean, just would that be any better, or just?
Yeah, if there is a device. I mean, the neurosurgeons use it all the time when they put ventricular drainage and stuff. So if that of course would speed up the surgery, but such a device is probably quite expensive. And I mean, the surgery you've seen was maybe 15 or 20 minutes. So I don't think it's, well, I probably wouldn't buy a thing like this.
Yeah, okay.
I mean, I did actually, for the first Bonebridge, we did check if the standard neurosurgical trepanation drill has the same diameter, which didn't. So you forgot about it. Yeah. Hamid Reza, you have a question to the audiological indication.
Exactly, dear Robert. So you want, so it was your question if you do have question about it. And I was for a short minute, I was not there. I wonder if you already have shown the audiological data with the Bonebridge afterward.
Yes, I did.
I'm sorry for that.
You want to see it again?
Yeah, if it's possible. Thank you very much.
Sure.
Because as I remember correctly, the bone connection was a little bit okay.
So we can go. This is the thresholds, the Puton thresholds prior the second surgery. Yeah. So on the left side, he's definitely out of range. On the right side, more or less as well. But what would be the alternative? I mean, the alternative would be going right away for a cochlear implant. On the other hand, we can, in order to check for an indication for a cochlear implant, we must have the speech perception under, measure the speech or test the speech perception under best aided conditions. So what is best aided for this patient? Conventional hearing aids, or like in this case, I think best aided condition is a bilateral bone conduction implant. So this was the Baha and wobble thresholds. So now let's look at the speech perception. So on the left side, we do not reach more than 60% monosyllables at 65 dB sound pressure level. So actually we would have on the left side, if you look at the guidelines of German ENT Society, we would have a cochlear implant indication. And on the right side, we reach at 65%, 65 dB SPL, 70% monosyllables. We do not have the indication. So in the end, of course, he's probably under this condition optimal aided, and going with him for cochlear implantation will be probably next step in the future. Patient is happy. Let's say, yeah. Is that okay? What is your opinion, Hamid Reza?
Yeah, absolutely, absolutely. I agree with you.
Would the sound bridge be an option for this patient as well?
Yes, audiologically, the sound bridge certainly would be an option, but if you use the Frenzel score on the temporal bones, we will see that we have very unfortunate surgical approach lines for the round window and the oval window. So that's why we decided for the Bonebridge.
Okay. Now we have a few questions left in the chat. Maybe start from the top. There was another question about dural hematoma after head trauma, putting pressure on the BCI. Any input on that?
No, I've not observed any of this, and from a mechanical point of view, I don't expect it at all. I mean, if you have, well, let's do something else. What you can better see. Yeah, I mean, if you have a bone bed and you put the BCI-FMT on top, yeah, which is screwed in here. So if you have a trauma, it will always be on the entire skull. I mean, it won't be the wings of the BCI-FMT, they don't move. I mean, if you have a trauma what moves the BCI-FMT or disembarks or bends those wings, then the patient has certainly more troubles than small hematoma around the BCI-FMT, I would guess.
Okay.
So Robert Week says 60%. Yeah. Hanover and the, yeah. So it's a comment, I think. Then Steve Will says, what Baha processor was the recipient using? Actually, I'm not. I can't tell you the name. It was the. It wasn't. It definitely wasn't the strong one. So. It was the power. It was the power device, but not. I mean, it wasn't the head worn or a collar worn device. It was the advanced one, the power device.
Mm-hmm.
So Jeffrey, so function pre-op, this patient was deaf, mostly correct. Exactly. Yeah. I mean, this patient is. This boy comes, he lives in an orphanage or grew up in an orphanage in remote areas. So he's now in a training to become a skilled worker. And as you say correctly, I mean, if you have 100% pulley syllables, he can definitely take part in normal conversations. Yeah.
No, I always say that for me that, 60%, even 70%, yeah, it gets really hard to talk to someone like this. So, but post-op, you can talk normally, so that's great.
Yeah. And maybe, yeah, it should look like a spoon. So, do you try with a vibrant sound bridge in the left side before cochlear implant? Actually, no. If this patient is unhappy with his speech perception, I think I would recommend a cochlear implant on the left side. So he will be then probably much better off with a bimodal stimulation of a bone bridge and the cochlear implant. Because especially in the, his thresholds in the between 500 and 2 kilohertz were around 60 dB. So I'm pretty certain that the cochlear implant will be the much better device then. Even the sound bridge is an excellent device. The amplification force won't be enough, and if you have such threshold shift, you must be aware that there is definitely inner ear hair cell loss, and if you have inner hair cell loss, then you can be as loud as you like. The patient won't understand better. He can hear better, but he won't understand better.
Do you also have other patients where you upgraded from a percutaneous device to Bonebridge?
Yes, both to Bonebridge and Soundbridge. Yeah.
Mm-hmm. Do you have an idea how they compare the devices audiological wise? Does it sound similar to them, or is there an improvement even audiological wise then?
Most of these patients, they how to put this is very. I mean, how come I had not to hear for so many years? I think most of the patients or lots of patients running around with Baha are not aided good. That's because, I mean, especially those being implanted in those times where there were no alternatives for Baha. I'm not talking about now, I don't know. But what we see is lots of patients what have been implanted in those years in the end of 90s and beginning of the century. You know, where everything was treated with a BAHA, what couldn't hear, and people wear those devices, but they don't understand. And then when you explain, or when they're being sent and you explain them alternatives, then implant them, they're really happy.
That's good to hear.
Yes, but particularly, Ms. Cavale, this question is really important. And a BC FMT or a regular FMT, so Soundbridge and Bonebridge, are only indicated if the patient has audiological measurements what are elective for a hearing aid and not a cochlear implant. So if a patient doesn't understand with a hearing aid, doesn't mean that Soundbridge or Bonebridge makes it better. You always have to check whether isn't this a patient for a cochlear implant. So this is very important when you select a patient. Yeah. So the Bonebridge and the Soundbridge are not better hearing aids. They are better hearing aids for patients what need a hearing aid but can't wear it. Yes, this is very important to think, because usually a normal hearing aid is better than a Bonebridge or Soundbridge, because it's just more modern, the sound processing and the microphones and everything, because they get updated every year, every month. Where due to the medical device regulation, those implantable devices can't be updated every now and then.
Then we have another question from Robert Wieck. How often do you see patients that are already on the sleeper screw for BAHA come for a Bonebridge, a Soundbridge, or a CI?
Actually, I didn't see any patient yet. So I can't tell. We have the patient. This is the most of the patients we change are now in their 60s or 70s. So in our region, there are not lot of children running around with this. Fortunately.
Okay, I think we answered all the questions. And there is no more questions coming in. So with that, I think we can end this session here today. I would like to thank you a lot, Professor Mlynski, for taking the time, for sharing this case, and also taking the time to answer all of those questions. Now I can see Hamid Reza. Do you have a question?
I wanted to say bye. Thank you very much for.
Okay.
Thank you.
Thank you very much, Hamid Reza. I just have one slide left, which I would like to put up now. And this slide is about our next event, which is already next week. So at the 8th of June, again at 3 p.m. in the afternoon, Middle European time. And this time we are going to talk about cochlear implantation in common cavity deformity. And we will have Professor Yongxing Li with us, who works in China in Beijing Dongguan Hospital. So we are looking forward to that. We hope we can see you there again. And with that, I wish you a nice remaining afternoon. Thank you all for your participation. And yeah, see you next week. Goodbye.
Bye-bye. Thank you very much, everybody.